Next, I'd like to demonstrate what I think is the best way to use the airQ as a rescue airway device. Now, people ask me all the time, why do you want to use an airway device to intubate with? Why not just use a laryngoscope? I think the best answer to that is if you use a standard airway as a conduit to intubate, you can ventilate with the airway. So when we get into trouble and we have difficult intubations, the first thing we're going to do is put some sort of airway in the patient to ventilate the patient so that we can get back our saturation levels and basically get back to square one. Now, if you're able to use that same rescue airway device as an intubation conduit, you can ventilate the patient right up to the attempt of intubation. And if you fail intubation, you can immediately ventilate the patient again. So, and I'm going to show you in a minute how you can actually use the airQ to ventilate while you're intubating. So the whole point is, as long as we're moving air, as long as we have the oxygen on, as long as we have the gas going, our patients won't get hypoxic, they won't get hypercarbic, and they won't wake up. That's why it's very important, because it's safer. If you can use an intubation airway device to intubate a patient when the patient's in trouble, it's safer than using some sort of laryngoscope, because the patient is apneic during the laryngoscopy. It's that simple. Now, I'm going to show you my 5-minute technique. I'll take you through a really easy cascade of how to intubate patients through an airQ. Now, if you fail at it, you can always take the airQ device out and use another device to intubate. So it's not an either-or situation. It's let's do the safe stuff first and then move on to the apneic situation that's a little bit less safe. Because remember, as long as we're moving air, not only is the patient safe, but we're safe as well. Now, the first thing you have to do when you intubate with airQ is to remove the connector. So what I'm going to do is grab the end of the airQ with my left hand, and I'm going to wiggle this connector out and pull it out like that. Now, typically I use the circuitry right next to me so that I can hang my circuit right onto the circuitry. So if I want to use it again to ventilate, I can just put it back and forth very quickly. Instead of having it back here on the anesthesia machine, I have the circuit right here and a circuitry ready to go. So I take the circuit off, I put it here, I take the connector off. Now the next thing that's important is you have to lubricate the airQ properly. There's a standard way to do the lubrication. You'll notice on the back of the airQ, next to the connector, there's a number with some arrows on it. Now, that number is the distance from the outlet of the airQ to the end of the breathing tube. So from here to here. Now, it's important because we're going to use that number during this intubation cascade. First, we're going to use it to lubricate the patient. So I take a standard endotracheal tube, and if I know I'm going to do this, I usually roll it into a little circle like this. It helps to put the endotracheal tube in a circle, because what we want the endotracheal tube to do is go around the curve, the hypercurve of the airQ, and up into the larynx. And by having it in a little circle like that, it seems to me it helps the intubation. Now, once I'm ready to intubate and I take this off, I take my endotracheal tube, and you want to suck all the air out of the endotracheal tube. So just put a standard syringe on there and just suck it all out until the pilot balloon is completely flat. Then I use just standard KY jelly, whatever you want to use, and I put it on the area where the cuff of the endotracheal tube is, and I sort of move it around a little bit. The next thing I'm going to do is I'm going to look at that number and see how far it is to the outlet of the airQ. On this particular device, the standard 3.5, it's 18. It's 20 on the larger adult size, and it's usually 2 less each time you drop down a size. Now, I'm going to hold the endotracheal tube tightly with my fingers and my thumb at that number, so that I could put the endotracheal tube into the airQ, spin it a little bit, and put it all the way down to that distal part, so that I can easily lubricate the entire length of the airQ tube, and also lubricate that length in the endotracheal tube at the same time. So I push it down there, and then I run it up and down a bunch of times and spin it a little bit until I get it very, very slick, and then I usually leave it in place. Now, sometimes if I have a patient that's really difficult and the patient desaturates very quickly, I'll just reach down at that point and I'll hook my circuit right up to the endotracheal tube, because the cuff of the endotracheal tube will seal the distal airQ tube up enough that you can actually put the connector here and squeeze the bag and ventilate the patient using the cuff of the airQ as the sealing point. So basically you don't have to completely dismantle this whole thing to ventilate with the patient once the endotracheal tube is in that sort of what I call the loaded position. Okay? So you put that, breathe a few times with oxygen and gas. Now I like to do is one standard blind intubation. Very gently blind, I'm going to try to place the endotracheal tube into the trachea. Now why do I do that? First of all, it's easy. Second of all, it doesn't cost anything. And the third thing, it's very, very quick. All right. Now what I found out after designing the airQ is that if you put the head in extension, so put the head in its normal intubating position, I usually hold on to the endotracheal tube like this. I usually put my index finger on the cap, and I usually push with my index finger on the endotracheal tube into the trachea so that I don't put too much pressure. So remember, it's a very gentle technique. Sometimes I reach around and I hold the cricoid ring with my left hand so I can feel the endotracheal tube slide by the cricoid ring. Sometimes I just position my hand here and I let a helper very gently put their fingers across the cricoid so that when the endotracheal tube skips past the cricoid ring, they can feel the endotracheal tube enter the trachea. Now you can actually feel that most of the time. Some patients you don't, but most of the time I can usually tell just by pushing here and holding here whether the endotracheal tube is into the trachea. So I'm going to hold the endotracheal tube like this. I'm going to put my index finger on the connector of the endotracheal tube and gently pass it forward into the trachea like that. Now, the next thing you want to do is you want to blow the cuff up on the endotracheal tube. You want to take a stethoscope, which I don't have right now. Put your stethoscope on, put your ventilatory device on, and squeeze the bag and listen to the stomach. Now you want to listen to the stomach to make sure we don't have an esophageal intubation, because if you miss with airQ, it's going to go in it's going to go into the esophagus. There's only two holes down there, the trachea and the esophagus. If it's not in the trachea, it's going to be in the esophagus. We want to make sure it's not in the esophagus, and I do that first by listening to the stomach while I very gently squeeze the bag. Okay? Now, if I don't hear bubbles, I move my stethoscope to the chest and listen for breath sounds. Okay? I can observe the endotracheal tube for humidification, and then I look up at the end-tidal CO2 monitor to find out if I've got end-tidal CO2. Now, don't look at the end-tidal CO2 monitor first. Listen for the bubbles first, then the chest, and by that time the end-tidal CO2 should register on your monitor. Now, let's assume that I didn't get it into the trachea. Let's assume I listened and I heard bubbles. What do I do next? Well, then I basically just take the air out of the endotracheal tube completely. I back the endotracheal tube up to that position I told you about. So on this one it's 18 centimeters, and you can tell that by the numbers on the endotracheal tubes. I usually put just about a cc of air into the cuff of the endotracheal tube like this to seal up the cuff of the endotracheal tube into the distal part of the airQ device. And then I'll either put my circuit straight up here and squeeze the bag and ventilate for a minute, or better yet, if I have a bronchoscopic side port adapter, I'll put that side port adapter on. I'll put my circuit onto the side port. I'll support my circuit with the tree that's already here, and I'm going to put them on the ventilator with low tidal volumes and higher rates and turn the oxygen and gas up. So now I have the endotracheal tube in position, and I have the flexible bronchoscopic adapter like this, and I'm ventilating the patient with the ventilator. I'll send my anesthesia helper, which is typically my scrub nurse, out to get my cart, which usually has my flexible bronchoscope on it. While the ventilator is moving, I'll take the cap off the top of the side port adapter. I'll run my flexible scope down the endotracheal tube into the trachea, and then simply pass the endotracheal tube into the trachea over the fiber optic bronchoscope. Notice that I would be able to ventilate the patient during this entire intubation. For me, this is the safest way to intubate through an airQ. You can actually ventilate the patient while you're putting the endotracheal tube in. It's very quick, very easy, and you don't need to be really skilled with a bronchoscope to do this. Now, if I don't have a bronchoscope and I miss blindly, sometimes I have this device. And this is the airVu. It's a special optical stylet designed to be used through the airQ. So how to use this is really simple. So I do the lubrication like I showed you. I put my circuit on and I ventilate a little bit to make sure that my oxygenation is appropriate. Then I pull the airQ. I take a little bit of the lubrication off like this and put it on the scope. I load the scope up like this, put the endotracheal tube on the scope. I adjust the position of the distal tip, usually so the scope is just inside the tip but below the Murphy eye, and I lock that into place. I put the light source on, like normal, lights up the tube. Then I'm going to use the curve of the airVu scope with the curve of the airQ device to roll it around the corner get a view of the larynx, and then watch as I place the endotracheal tube into the trachea. So you're not meant to put this thing into the trachea. What you're trying to do is get yourself into a position so that you can directly see the larynx and the glottis ahead of you, and then simply watch as you guide the tube. There's some advantage to that. Since this is a rigid scope, you can steer it and adjust the position of the tip of the device. You can also put this in a position to lift the epiglottis if the epiglottis is in the way. Occasionally it happens very few times, but occasionally it will downfold. And you can simply roll it around the corner, get a view of the trachea, center the view with the larynx, and I'm just going to very easily reach up and gently pass the tube into the trachea under visualization, and then I'm just going to roll this back out. To help the mannequin a little bit, roll this back out, and I've got the patient intubated under visualization. Now, the flexible fiber scope and the airVu scope are my two go-to devices when I want to look. I typically try one blind intubation because it's really quite simple, and if you do it gently, it doesn't hurt the patient. And about 70% of the time, when you pass the endotracheal tube through airQ with the head and extension, it'll go in the trachea on the first pass. I don't try multiple attempts because I'm afraid of excess trauma, so if I don't get it on the first try, then I back it out, I send my scope, or I reach down for the airVu scope, I intubate it under direct visualization, and it's really quite simple. Now, once you get the patient intubated, you have a couple choices. You can leave the device in, and if it's a short case, if it's less than, an hour and a half or 2 hours or whatever, it's a short case, I'll simply take all the air out of the airQ device and do the case with the whole business in, the airQ and the endotracheal tube. So I'll just hook my connector here. I usually tape this to the mandible, the airQ. I'll tape the endotracheal tube to the airQ tube, and I'll put my circuit on here and just do the case. At the end of the case, I'll take the air out of the device, remove the endotracheal tube, and then remove the airQ later if I need to ventilate a little while in between the removals. This way you can use the airQ as an emergent device, sort of what they call a double-stage extubation. Now, if I need to get the device out for any reason, it's really quite simple. And we do that with one of these stylets. This is the airQ removable stylet. This is the large size. It's a size 1. It comes in 3 sizes. The size 0 that I use for the sort of middle 2 sizes of airQ. I use this for the 2 adult sizes. And a little teeny one called the 00 that I use for the infant devices. We're going to use the size 1 on the size 3.5. The first thing I'm going to do is I'm going to take all the air out of the cuff of the endotracheal tube and all of the air out of the airQ device. Okay? Now, I usually lubricate the pilot balloon of the endotracheal tube so it'll slide through the airQ a little easier. Then I'm going to remove the connector of the endotracheal tube by grasping the endotracheal tube here. Sometimes I need a 4x4, sometimes this is a little 6, so I put a 4x4 here and grab it. Take this device, and you put this device on the circuit or in your pocket so you won't lose it. I'm going to set it here, but I don't like to set these connectors down because you're going to have to put it back into the endotracheal tube to use it. Now, the next thing I'm going to do is I'm going to take the removable stylet and I'm going to start pushing it into the tip of the endotracheal tube. And as I'm pushing down, I'm going to spin it clockwise to lock these two together. So I'm actually screwing the stylet into the end of the endotracheal tube. So I'm not just using it as a pusher, but I have total control of the endotracheal tube as I can move it back and forth. You'll also notice with the stylet that there's grooves in here. So if the patient's breathing spontaneously, you can easily breathe around the stylet within the endotracheal tube, so you won't sort of cork up the airway of the patient. So it makes it so that he can breathe while you're removing the stylet. Typically in anesthesia, our patients aren't breathing spontaneously. Sometimes they are. Now, the next thing I'm going to do is cheat a little bit. What I'm going to do is I'm going to push the endotracheal tube into the lungs a little deeper first. So I'm going to run the tip of the endotracheal tube down to the carina or so that I can give myself a little space down there so that I won't intermittently extubate them. Once I get the pilot balloon about in this position, right here, so that the pilot balloon is just starting to enter the airQ, I stop pushing the stylet and I just hold it in place. So I'm going to use counter traction on the stylet as I remove the airQ. The next thing I'm going to do is as I take airQ out, instead of going around the corner, instead of using the curve of the tube to go forward, I'm going to straighten the tube up with my fingers so I can pull it straight up in the air. So watch. I'm going to hold this, I'm going to start backing this out, I'm going to straighten it up, pull it straight out using counter traction, and lift it off the device, and I'm going to simply reach down in here and unscrew the stylet. This is very easy to do. It's important that you practice screwing the stylet in and out of an endotracheal tube for a while before you try it on your first patient. But after a very short period of time, you'll be able to take these out really easy and fast with no problem whatsoever. Once you get done, replace the connector of the endotracheal tube. I usually air up the cuff of the endotracheal tube first, and then I adjust the position of the endotracheal tube to get the depth right. And then first thing I do is check the ventilation of the patient. As you can see, we're in the trachea.